Continue,
Go ahead,
Likith.
Likith. Go
Can
ahead.
hear you.
That is wait.
I can see the slide.
I am not seeing.
Presenter view may have caused confusion. Just exit the presenter view.
Is it coming, sir?
I can see the slide.
Yes, sir.
We are seeing the slide, Likith. You can.
Okay. Yes. Good evening, all. My class is on lung cancer. Today, lung cancer refers to the tumors originating in the lung parenchyma or within the bronchi. It is one of the most leading causes of cancer-related deaths and most commonly diagnosed cancer on worldwide, accounting for approximately 12.4% of all cancers. And according to Global Cancer Statistics report from 2020, lung cancer remained the leading cause of death worldwide with an estimated 1.8 million deaths. And the survival is stage specific. Overall, one year survival rate is 44% and 5-year is 17%.
Likith, it is the leading cancer, number one cancer in the West, like
Yes.
America, Europe, and Australia. Is it the number one cancer in India?
Number one cancer.
Or where does the lung cancer numbers stand in India? It is number two cancer among the males. It's number three cancer among the women. Before you logged in, we were discussing that. Head and neck cancer, oral cancer is the number one among the men. Second is the lung cancer. In women, probably cervical cancer number one, breast cancer number two, and then comes the lung cancer. So it is a significant burden in India also.
Yes.
Apart from being an exam-oriented question, when you are practicing as a clinician, when somebody known to you or when your patient comes with some symptoms, you should have the basic knowledge of lung cancer. Okay?
Yes, sir.
Continue.
Coming to the etiology, smoking is the most common cause, and 90% of lung cancer cases are due to smoking. And other factors include radiation exposure for non-lung cancer treatment, especially in non-Hodgkin's lymphoma and breast cancer. And asbestos and radon exposure are established risk factors, and exposure to metals such as chromium, nickel, and arsenic and polycyclic aromatic hydrocarbons are also associated with lung cancer. And lung diseases like idiopathic pulmonary fibrosis increase the risk of lung cancer, and those who have family history and with genetic mutations.
Family history of lung cancer or the oral upper GI malignancy cancers. In which profession do you get the exposure to these aromatic hydrocarbons?
In PVC industry, plastic industries.
Electroplating industry, exposure to arsenic and others in mining, zinc sheet manufacturing.
Yes.
Scar cancer is also a known entity, especially in India, because many of them will have lung infection, especially tuberculosis, which invariably heals with scars. Sometimes that can become a cancer. Higher incidence among the scars is well known in the lungs.
Yes.
Okay?
Yes, sir.
Okay, continue.
Sir, but is hereditary point relevant in general practice, sir? Like if you find a problem in a father, would you be screening the?
Family history is one of the factors when you consider for lung cancer screening programs.
Okay, sir.
Above 60 years of age, smoker or ex-smoker of less than 10 years duration, family history of lung cancer or family history of upper GI malignancy will be one more factor. Those will be the admitted for the lung cancer screening, low dose CT screening for lung cancer. So family history is very important. Any other question?
No, sir.
Okay, continue.
Okay. And lung cancers are classified into small cell lung carcinoma and non-small cell carcinoma and further subtypes like adenocarcinoma, squamous cell carcinoma, large cell undifferentiated carcinomas. And
Special entity called neuroendocrine
Neuro-
tumors
Yes.
should also have been mentioned here.
Yes, sir.
It's a separate entity by itself. You cannot put it either in the small cell or non-small cell. But the lung is a commonest organ involved by neuroendocrine tumors.
Yes, sir.
Okay. Continue.
Coming to adenocarcinoma, it is the most frequent histologic type, account for 45% of all lung cancers, and the 75% of tumors are peripherally located. And adenocarcinoma pathology consists of either neoplastic gland formation and or pneumocyte marker expression like thyroid transcription factor 1 and intracytoplasmic mucin production. And this is further classified based on the extent and architecture of neoplastic gland formation, such as mucinous or non-mucinous types. And solid micropapillary and cribriform subtypes have adverse prognostic significance, and these tumors metastasize most frequently to central nervous system.
Correct. Continue.
Yes. Coming to squamous cell carcinoma, it is defined by the presence of keratinization and intercellular bridge formation in the bronchial epithelium, and expression of immunochemistry immunochemistry markers like P40, P63, and CK5 or desmoglein. And these tumors are centrally located and tend to expand against bronchus, causing compression, and show extensive central necrosis with resulting in cavitations. And there are subtypes of squamous cell carcinoma include non-keratinizing, keratinizing, and Bessel types.
Keratinization is the characteristic feature of squamous cell carcinoma anywhere in the body.
Yes.
Whether it's in the skin or the lung. Pathologists will call it squamous cell carcinoma if they see keratinization more confidently. Okay.
Yes.
Then comes the IHC. So they are more of a central tumors, like in the major airway.
Yes.
Okay, continue.
And large cell carcinoma, it is a malignant neoplasm that does not have any cytologic features consistent with glandular and squamous and neuroendocrine tumors. And they do not typically express P40 and TTF1 on immunohistochemistry and lack cytologic features of small cell carcinoma. And typically, this large cell carcinoma is comprised of round to polygonal large cells with prominent nucleoli and abundant cytoplasm.
Then why is it classified among the non-small cell lung cancers?
Sir?
In the first slide, when you said they are classified into small cell and non-small cell,
Yes.
non-small cell includes adenosquamous, large cell, etc., multiple varieties. Why are they subdivided like that? Has anyone asked this question to yourself?
No, sir.
Based on the size of the cells, like nucleoli size and all.
No. That is based on the cytology characteristics. You define them into adenocarcinoma, squamous cell carcinoma, large cell, etc., anaplastic carcinoma, mucinous carcinoma. Variety are there, multiple subtypes, but they are all put into non-small cell lung cancer. Why is it?
The
Based on
management for small cell and the nature of the course of the disease is completely similar for entire
Correct. You are right. You are
under
right.
non-small cell and
Yeah, the staging and management and the outcome for small cell cancer versus staging, the management and outcome for non-small cell cancers is almost similar irrespective of cytology. That's why they are put into two broad categories.
Okay, sir.
When you made that slide divided into two, did you not ask yourself, why is it so? Likith?
Yes, sir.
That is the basic curiosity if you want to succeed as a clinician. At least you should make this slide by yourself. That's the reason when you are making this slide, this question should come up. Why is it divided into only two? Why not each cancer as a separate category? Not necessarily this topic, any topic or any, whenever you are preparing a slide,
Yes.
you should ask yourself, why is it? Okay, continue.
And small cell lung carcinoma is a type of neuroendocrine tumor and represent about 20% of all lung cancers. These are extensively necrotic, and microscopically the tumor appear as sheets and clusters of cells with dark nuclei and little cytoplasm. And they usually stain with positive with chromogranin and synoptophysin. And these tumors are centrally located and spread early to mediastinal lymph nodes and distant sites, especially bone marrow and brain.
Continue.
Yes. And pathophysiology and repeated exposure to carcinogens leads to dysplasia of lung epithelium. If the exposure continues, it leads to genetic mutations and affects protein synthesis, and this in turn disrupts the cell cycle and promotes carcinogenesis.
This is the pathophysiology, how a normal cell becomes uncontrolled division and a cancer cell in any cancer for that matter.
Yes.
Okay, what triggers that uncontrolled proliferation? How does it lose the control in the homeostasis? That's a different story. But this is the basic pathology for any cancer. You can write it for any cancer.
Yes, sir.
Okay, continue.
And the most common genetic mutations are for small cell lung cancer, MYC and BCL2 and P53. And for non-small cell lung cancer, EGFR, KRAS and P16.
Okay.
Yes. Presentation, there are no specific signs and symptoms for lung cancer, and patient usually presents with symptoms of cough, hemoptysis, chest pain and dyspnea. And pleural involvement in lung cancer can manifest as pleural thickening and nodules and malignant pleural effusion. And this superior vena cava syndrome is due to dilated neck veins and edema of face, neck and upper extremities is a common feature of small cell lung carcinoma. And these lung cancers in the superior sulcus present as Pancoast syndrome. This presents as shoulder pain, Horner syndrome, and atrophy of hand muscles.
Basically, involvement of neurovascular structures at the apex of the chest or the root of the neck.
Yes.
That's where you call it as a Pancoast tumor.
Yes.
Superior sulcus tumors. Okay.
Yes.
They can also present sometimes with fever, chest pains, typical of a infection. Say, for example, the tumor is obstructing one lobe, right lobe, upper lobe bronchus, or left lower lobe bronchus, and that lobe becomes consolidated because secretions cannot be expectorated out. That gets infected. Then they present as pneumonia, empyema. In a patient who presents with pneumonia and you treat it and then it remains unresolved, non-resolving pneumonia, you need to rule out obstruction to the bronchus. One common cause for such patient non-resolving pneumonia is a tumor obstructing the bronchus. Okay? Continue.
Yes, sir.
So can I ask one small
Hmm.
question to Likith?
Yeah.
Likith, tell me what are the components, parts of the Horner syndrome? What all do you see in a patient who has a Horner syndrome?
That's a question in the exam also, short question. What is Horner syndrome? Why is it caused? And what are the components?
Horner syndrome,
Hmm.
drooping eyelid,
Hmm.
and
Also called as
Sir?
drooping eyelids is called as what?
Yes.
Ptosis.
Ptosis and constricted pupil meiosis
Hmm.
and unilateral sweating, facial
Anhydrosis.
anhydrosis.
And not
Decreased sweating on one side of face. It is Anhygrosis.
Why is it? What causes it? Damage to what causes Horner syndrome?
Sympathetic chains.
Yeah, what is that ganglion called?
T1.
When the sympathetic trunk enters into the chest from the root of the neck, it forms a ganglion. What is that ganglion called? Anything to do with yes? Somebody else can answer. Stellate ganglia. Okay.
Okay.
Okay, continue.
Yes.
Next.
And patients may present with bone pain at the site of metastasis and also have elevated serum alkaline phosphatase and hypercalcemia. And imaging usually reveals osteolytic lesions with vertebral bodies as most common site of metastasis.
What is the most common cause of elevated serum alkaline phosphatase levels apart from liver disease?
All infection.
You just said it now.
In bone formations.
Bone metastasis. If you exclude the liver disease, bone metastasis, common cancer for one of the common cancers for bone mets is the lung cancer. Okay, paraneoplastic syndromes. Mention them.
Yes. Paraneoplastic syndromes associated with lung cancer. Symptomatic hypercalcemia is secondary to lung cancer, may be due to secretion of parathyroid hormone and or due to extensive bony metastasis. And these patients present with anorexia, nausea, constipation, and lethargy, and have overall poor prognosis. And syndrome of inappropriate antidiuretic hormone secretion is associated with small cell lung carcinoma and present with symptoms of hyponatremia. And neurologic paraneoplastic syndromes are associated with small cell lung carcinoma, and which include Lambert-Eaton myasthenic syndrome, encephalomyelitis and limbic encephalitis, cerebellar ataxia, autonomic and sensory neuropathy. And this ectopic adrenal corticotropin production can cause Cushing syndrome and is associated with small cell lung carcinoma, large cell neuroendocrine carcinoma, and carcinoid tumors.
Correct. What else do you get in the hands and fingertips?
Fingertips.
Somebody else can answer? Chronic smokers, you examine their fingertips. Huh?
Clubbing of nails.
Yeah, you can include that also as a paraneoplastic syndrome. That's more common than what you have mentioned so far. What is higher grade of clubbing?
Hypertrophic pulmonary osteoarthropathy.
Yeah, give preference to the exam going or junior PGs. Okay, continue.
Yes, sir.
Next. They need to put their brain into work, not the registrars. Continue.
Yes. Coming to the TNM staging of non-small cell lung carcinoma, and it is an internationally accepted staging. It is comprehensive in defining the tumor size, extent, location, and distance spread, which helps clinicians to draw conclusion regarding the treatment. And most recent TNM classification is 9th edition by International Association for the Study of Lung Cancer. This is the TNM staging. A primary tumor is divided into five categories, and T0 is no evidence of primary tumor. TIS is carcinoma in situ. T1 is tumor less than 3 centimeters. And T2 is tumor greater than 3 centimeters but less than 5 centimeters. T3 is tumor greater than 5 centimeters but less than 7 centimeters. And T4 is greater than 7 centimeters with following findings.
There's a whole lot of criteria to call it, even if it is a 2 centimeter lesion, if it is involving the parietal pleura or invades into chest wall or invades into mediastinal pleura, it goes into T3. So size by itself is not a criteria. And also the where it is located. If the tumor is 1 per centimeter is located in the close to the right main bronchus, is a different stage. You need to spend some time to understand this T staging, N staging, M staging in lung cancer. It's not as easy as other organs.
Yes.
Okay?
Yes.
Continue. See the T4, for example, not necessarily more than 7 centimeters. Just touching the mediastinal pleura is T3, but invades into the other organs in the mediastinum becomes T4.
Yes.
Okay?
Yes.
Continue.
And coming to the thoracic lymph nodes, lung cancer staging also depends upon the extension of cancer to the lymph nodes corresponding to the primary tumor. And thoracic lymph nodes can be divided into mediastinal N2 and hilar N1 lymph nodes. N2 nodes are important because they differentiate in cancer stages. Coming to the mediastinal lymph nodes, these are subdivided into following groups like supraclavicular lymph nodes, which is station 1, and superior mediastinal nodes, station 2 to 4, and aortic nodes, station 3, and inferior mediastinal lymph nodes, which is station 4. And next group is aortic lymph nodes. This group includes subaortic nodes, which is station 5, and para-aortic nodes, and which is station 6. And next group is inferior mediastinal lymph nodes, which consists of station 7 as subcarinal lymph nodes, and station 8 is paraesophageal lymph nodes, and station 9 is pulmonary ligament nodes. And last group is hilar lymph nodes, which is N1. It contains station 10 to station 10 to 14.
You have made a good effort. Yeah, okay, continue.
Yes. And these hilar lymph nodes are N1 nodes, which includes nodes adjacent to the main stem bronchus and hilar vessels. On the right side, they extend from the lower rim of azygus vein to interlobar region. On the left, from the upper rim of the pulmonary artery to the interlobar region.
Next.
This is the regional lymph nodes class N classification. N0 is no lymph node, and M1 is involvement of ipsilateral N1 ipsilateral lymph nodes, and N2A is single N2 station involvement, N2B is multiple N2 station involvement. N3 is metastasis in contralateral side. And M0 is no distant metastasis, and M1 is distant metastasis with the following subtypes.
It is much, this 9th edition classification is much different from the earlier classifications. In this, we have included N2A and N2B because how you manage them and overall 5-year survival, 10-year survival is altogether different if the patient has a single station ipsilateral lymph node versus multiple N2 nodes. Similarly, a patient has a solitary extrathoracic metastasis, like in the adrenal or in a rib or in the bone, you can still manage them with the intent of cure without any compromise. Sometimes you do achieve a good 5-year survival. That's why that is not just M0, M1, M1A, B, C, D, etc. Okay?
Yes.
Yes.
Okay. Continue.
This is the staging of lung cancer.
This way it is easy to stage and grouping together for a clinical decision making. You can see the number of choices you have for stage 1, stage 2, stage 3. So if somebody asks, how do you manage stage 3A lung cancer? It is entirely different. It also depends on the tumor size. It also depends on the lymph nodes present or not, whether chest wall involvement is there or not, etc. What is the idea of classifying like this, Likith?
Sir, staging depends upon the
Basically, stage 1, you can directly take them for surgery.
treatment.
Stage 2A, 2B, 2A also you can directly consider for surgery. 2B and 3A, you should consider them for neoadjuvant downgrading, reassess the response. If they are responding, controlled disease, consider for surgery followed by adjuvant treatment. If it is beyond that, you have to ask yourself, can you really cure it, or is it only for palliative treatment? That's the whole idea of putting this into a simple table. Okay,
Yes.
continue. Who has a doubt?
No, sir.
Continue.
And the evaluation, the overall goal is timely diagnosis and accurate staging. As per American College of Chest Physician guidelines, the initial evaluation should be within 6 weeks in patients with tolerable symptoms and no complications. Only 26% and 8% of cancers are diagnosed at stage 1 and 2, and whereas 28% and 38% are diagnosed at stage 3 and stage 4 respectively. And lung cancer evaluation can be divided as radiological staging and invasive staging.
Essentially, what he is saying is, even in the West, including US, UK, Canada, Australia, early diagnosis is only in less than 20 or at the most 25% of the patients with lung cancer, meaning large majority of the patients at the time of diagnosis are advanced, locally advanced, and generally with multi-organ metastasis, not a curable stage. That's where the concept of low-dose CT and screening for lung cancer, early detection, curative treatment with a better long-term outcome comes in. Needless to say, in India, early detection is less than 10%. It's actually labeled at Tata Memorial Hospital says it is 3 to 5% only in Indian patients we diagnosed early in stage 1 to be able to achieve a cure. That's the summary of this slide. Yeah, radiological and invasive. Continue.
Yes. Radiological staging. Every patient suspected of having lung cancer should undergo this CT. In intravenous contrast, IV contrast is preferable as it distinguishes mediastinal invasion of the primary tumor or metastatic lymph nodes from vascular structures. And the main objective of CT scan is to identify the extent of the tumor, its anatomical location, and the lymph node involvement. The overall sensitivity of CT scan to identify malignancy is 55% and the specificity is 81%.
Continue.
Yes, sir. And this next is PET scan. PET scan provides information on the primary tumor's metabolic activity and mediastinal involvement and potential distant metastasis. It can also identify recurrence versus metabolic changes post radiotherapy. And in this, false positive occurs in patient with active infection and inflammation with increased glycolysis. And false negative PET scans occur when there is impaired blood flow and low metabolic activity, in such as people with carcinoid tumors and some adenocarcinomas and smaller lymph nodes.
What are the two common PET scans done in India? What you have heard of or written the request for?
FTG and
DG.
And
Dotonac.
Dotonac, sir.
You should do a class on PET scan itself. What do you mean by FDG?
Fluorodeoxyglucose.
So high glucose turnover, high turnover should be there in the cells. In a slow growing tumor like a neuroendocrine tumor or a carcinoid tumor, FDG PET is not recommended. You go for a Dotonac PET CT. What does it detect? Somatostatin receptors. And in a patient that we recently operated middle lobectomy, it was a foreign body with a joint cell reaction. The Dotonac PET CT, they had clearly written very low affinity for the Dotonac PET CT. That should have given us a clue, although bronchoscopically biopsy, they declared it as neuroendocrine tumor. Dotonac scan showed very low affinity. That should have raised the suspicion that this may not be a tumor. Okay.
Yes, sir.
Interpretation matters. More false positives in India because of the high incidence of infection, high incidence of tuberculosis. Any lesion that is metabolically active, any infection becomes positive on the PET scan.
Yes.
Okay. When you are talking about workup or workup for any malignancy, you should always divide it into for diagnosis, for staging. Under those subheadings only you have to discuss. Okay, continue.
Yes. And after PET CT and PET scans, the next step is to obtain tissue or pathologic confirmation of malignancy and confirm the staging and histological differentiation of cancer. And these are
1
the
second.
following. These are the
Sir,
Yeah, go on.
sir, is there any role for MRI, sir, for lung cancers?
Probably he will mention it in the next slide. When your patient has a tumor from the upper lobe infiltrating into brachial plexus, superior sulcus tumor or the pancreas tumor, only in those patients we do MRI to evaluate brachial plexus, whether they are infiltrating or only a compression effect and involvement of the axillary vein, brachiocephalic vein, whether you need to plan for a reconstruction of those vessels. Only in that set of patients you do MRI.
Okay.
And there are institutes like Kidwai and Tata Memorial Hospital, even in stage 1, stage 2 patients, even if the PET CT is negative, they do MRI or a CT of the brain because that picks up about 4 to 5% of patients' brain metastasis, even though PET CT is negative. Only 2 such indications for MRI.
Okay.
Continue.
yes. And these are the following procedures: bronchoscopic endobronchial ultrasound with the transbronchial needle aspiration and endoscopic transbronchial needle aspiration and mediastinoscopy and thoracoscopy or video assisted thoracoscopy and CT guided transthoracic biopsy.
Okay, continue. Yeah.
And management of non-small cell lung cancer.
I asked you to mention the staging of small cell lung cancer.
Sir, in the last
slides?
In the last slide,
Okay, you have it. Okay, continue. Yeah.
Yes, coming to the management of non-small cell lung cancer. In stage 1, the surgery is the mainstay of treatment. The procedure of choice is either lobectomy or pneumonectomy with mediastinal lymph node sampling. And the 5-year survival rate is 78% for 1A stage and 53% for 1B disease. In patients who do not have the pulmonary reserve to tolerate pneumonectomy or lobectomy, a more conservative approach with wedge resection or segmentectomy can be done.
What is the alternative to surgery in stage 1 lung cancer? What is the form of radiotherapy that they do with a curative intent? Can somebody expand what is SBIRT? Please read it. In a patient really not fit for a surgery or anesthesia, diagnosed with a small lesion like this, you can do curative intent radiotherapy. SBIRT it is called. Read about it. That's the alternate. Next.
Stage 2, in stage 2, preferred treatment is surgery followed by adjuvant chemotherapy. And if the tumor has invaded the chest wall, then an in-block resection of the chest wall is recommended. In Pancoast tumor is a unique tumor of stage 2, which arises from the superior sulcus, and the treatment of choice in cases of Pancoast tumor is neoadjuvant chemo followed by etoposide and cisplatin, and concurrent radiotherapy followed by resection. And overall survival rate is 44 to 55%, 54%. In stage 3, 3A performs surgery as planned and followed by adjuvant chemotherapy and concurrent chemoradiotherapy. In T2, T4 tumors are usually treated exclusively with chemoradiation. In stage 3B tumors, these are treated as the same way as unresectable cancers are treated with only concurrent chemoradiotherapy.
Okay, I'll just summarize with 1 or 2 sentences. Locally advanced lung cancer, like lymph node involvement, just one involvement, etc. You should always do a neoadjuvant treatment, 2 or 3 cycles minimum. Reassess the response with a PET CT. If they are responding, then you consider surgery followed by adjuvant therapy. If they are not responders, they directly go for palliative chemoradiotherapy. Advanced one, like you said, is palliative or curative intent chemoradiotherapy. Okay, that's the summary you need to keep in mind. Continue.
Yes. Stage 4 disease is considered as incurable, and therapy is aimed at improving survival and alleviating symptoms. Only 10 to 30% of patients respond to chemotherapy, and only 1 to 3% survive 5 years after diagnosis.
Okay, this is where 9th edition of staging comes into picture, more obvious than in the other stages. M1A, solitary metastasis, which is resectable, where complete resection is possible, not debulking. Maybe a met in the vertebra, maybe a met in the adrenal, or maybe a small nodule in the other lobe of the same side. That's also M1A. If you can resect it completely, you can achieve a reasonable up to 30 to 50% 5-year survival. And there are targeted therapies based on the genetic mutations that you analyze. And some of them survive for several years with those treatments. That's the whole difference between 8th edition and 9th edition TNM staging. Continue.
Yes.
No, you don't waste your time on VATs. Okay, you quickly mention this and move on. Yeah.
Yes, sir. Yes. Coming to video-assisted thoracoscopic surgery, Dr. Hans Christian Jacobius was the first physician who performed this procedure, and it is minimally invasive and cause less post-operative pain and result in reduced hospital stay and quick recovery. And this is used as diagnostic and therapeutic indications.
And for registrars, what did he use to do thoracoscopy, Jacobius? Obviously, he didn't have a designated laparoscopy or thoracoscopy instruments at that in his era. What instruments or what scope did he use to look into the abdomen and chest? Any idea?
No, sir.
Telescope.
Jacobius did first thoracoscopy using what type of instrument or what type of visualization? Cystoscope. Laparoscopy instruments or thoracoscopy cameras were not there at that time. You put the cystoscope into the pleural cavity to visualize. That's how we did the first thoracoscopy. Continue.
In this, patient is positioned in lateral decubitus position, and one lung ventilation method is used. And these are the approaches. First is triportal anterior approach, and second is triportal posterior approach, biportal approach, and uniportal approach, subxiphoid and subcostal approaches. And these are the contraindications of VATS. Absolute contraindications are inability
Skip
to
this
solve.
slide. Skip this slide.
Okay. Yes.
Sir, are there any like advantages of this subcostal or xiphoid approaches, sir? Are
It
they
is
just
supposed to be like in a model involved in beauty pageant. Scars on the chest may not be such a good idea. Or when you are doing a central tumors like a thymectomy, sometimes we struggle with the camera and the instruments. So that time you can use the subxiphoid port for the camera. And then people thought, why can't I do the same entire thymectomy procedure with the subxiphoid approach? It's just the variations. It's just the surgeon's experience and availability of those special long curved instruments for you to reach from that area to the area of the lesion.
okay,
Nothing
sir.
more than that.
Customization just.
Customization, yeah. You know, if you are attending a conference with 100 thoracic surgeons, how do you make yourself a distinction? Non-intubated thoracoscopy is one, subxiphoid thoracoscopy is one, uniportal thoracoscopy is the other, various modifications. Don't worry about that. Continue.
Yes.
Skip this slide. Yeah. Skip this slide. Yeah.
Yes.
Come to, okay.
Yeah.
Hmm.
And coming to the targeted therapy for non-small cell lung cancers, these are the tyrosine kinase. Example of tyrosine kinase inhibitors are erlotinib, geftinib, and afatinib. And ALK inhibitors like anaplastic lymphoma kinase inhibitors are crizotinib, ceritinib, alectinib. And ROS1 inhibitors are crizotinib. And this immunotherapy for non-small cell lung cancer are this nivolumab and pembrolizumab, which are IgG4 against PD1 receptors, and IgG1 against PDL1 is atezolizumab.
Okay, next.
Treatment of for small cell lung carcinoma. Uh, this this is limited stage in stage 1, limited stage small cell lung carcinoma without mediastinal or hilar lymph nodes. Lobectomy. The preferred treatment is lobectomy followed by adjuvant chemotherapy. In limited stage small cell lung carcinoma with mediastinal involvement, first chemotherapy followed by radiotherapy. And in extensive stage small cell lung carcinoma, on platinum based chemotherapy is considered, and overall survival rate for small cell lung carcinoma is 8 to 13 months.
Okay, do you realize it is small cell lung cancer is divided into only two, limited stage and extensive stage. Limited stage, meaning to say that there may be a chance for cure, but unlikely. More by and large, by the time you diagnose a small cell lung cancer, they will be advanced and they are not suitable for a curative treatment. Surgery is done in a case of small cell cancer where you have a small nodule in the peripherally located, where the histology has been reported as non-small cell cancer, or multiple attempts to prove the diagnosis is not possible, and then you operate, and then post-operatively comes a small cell cancer. I'm yet to operate on a patient with a small cell cancer which is limited and amenable for surgery. That aggressive these cancers are. Okay, next.
Yes.
Is that the end?
Yes, this last slide.
Hmm.
In palliative care, surgery results in better outcome in patients with at least 3 months of expected survival And surgical procedures for palliation include tumor bypass procedures and partial resection of tumor and removal of metastasis. Surgical intervention may be beneficial in patients with lung cancer if there is airway obstruction or hemoptysis, pleural or pericardial exudate, or metastasis to brain or bone. And chemotherapy helps in alleviate symptoms of pain, cough, and may prolong survival. Palliative radiation provides symptomatic relief in 45 to 95% of lung cancers. And endoscopic treatments such as brachytherapy helps to control symptoms due to airway narrowing.
Okay, any questions? He has done a good effort to highlight us the basics. There's a lot more to it. There are 1 week conference only on the lung cancer, only on genetic mutations, 1 day conference. Don't worry about all those things. But he has given us a good broad overview of lung cancer staging and management. Thank you, Likith. If there are no more questions, we will close. Are there any questions, PGs?
Yes.
Everyone is silent.
No questions, sir.
Okay, close it. Thank you. Good
Thank
night.
you. Thank you, sir.
Good night.
Thank you.
Thank you, sir.
Great.